Incidence of COVID-19 in Ecuador. Definition: the COVID-19 pandemic in Ecuador is an expansion of the COVID-19 outbreak that started in Wuhan, China. This fact alerted all the countries of the world since the beginning of 2020, and in mid-February it reached Latin America. In Ecuador, the first case was imported from Madrid, Spain. A 71-year-old woman who arrived in the country on February 14th later presented symptoms related to the disease, but it was not until February 29 that the Ministry of Health Public of Ecuador announced the first confirmed case of coronavirus, to being the third country in the region to present infected within its territory.
Virus was identified in December 2019 in China. Every day, we learn more about the virus. Novel coronavirus can cause mild symptoms, including a runny nose, sore throat, cough, and fever. Symptoms can be more severe for the elderly and people with underlying health conditions. It can lead to pneumonia, breathing difficulty, or in very rare cases, death. Novel coronavirus COVID-19 has spread to other countries, including the U.S. According to the Centers for Disease Control and Prevention, CDC, the risk of contracting the disease is low for the American public due to the ongoing public health efforts and screenings. The CDC has an evolving list of countries with specific travel restrictions and notices. If you are planning to visit or have recently returned from an area where COVID-19, the coronavirus transmission, has occurred, we ask that you take precautions and refer to the cdc.gov website for the latest travel recommendations. To help reduce your risk of contracting any respiratory illness such as the flu, wash your hands often with soap and water for at least 20 seconds. If you're not able to, use an alcohol-based hand sanitizer. Clean and disinfect surfaces frequently. Avoid touching your eyes, nose, and mouth, and avoid contact with people who are sick. If you are sick, stay home and drink plenty of fluids. If you have a fever, take fever medication, and be sure to cover your cough with your arm or tissue. If you believe that you are at high risk for the novel coronavirus COVID-19, contact your healthcare provider immediately. Describe your symptoms and travel history or contact with recent travelers to that region. For more information about the novel coronavirus COVID-19, go to the Harris County Public Health website at www.hchtx.org or visit the CDC website at cdc.gov.
Treatment: your healthcare provider is the one who should prescribe the treatments used for COVID-19. There are people who have been seriously harmed and even died after taking products not approved for COVID-19, even though they were products approved or prescribed for other use.
And some clarification from health experts today after the wave comments from the WHO's chief scientists were reported yesterday. Some Canadians found her remarks about mixing vaccines confusing.
It will be a chaotic situation in countries if citizens start, in mind who they should be taking a second or a third or a fourth dose.
Today, the WHO clarified that it meant individuals should not decide for themselves and should instead listen to their public health agency's advice. Canadian health officials say the comments were actually meant to address concern about a rush on vaccine supply and global equity. They remind Canadians that mixing vaccines is safe and effective. For more on this, we're joined by Dr. Isaac Bogosh, part of Ontario's Vaccine Distribution Task Force and an infectious disease specialist joining us from Vancouver. Dr. Bogosh, the misinterpretation of the WHO's message yesterday really caused some distress for Canadians who have missed their first and second doses of the vaccine. Can you clarify the WHO's message?
Yeah, absolutely, and I'm glad they clarified it as well. Basically, they're stating that it is okay to mix and match vaccines. What they were referring to yesterday was people who've completed a full vaccine series and then have started adding extra vaccines on top of that and doing this under their own volition, not under the guidance of public health, which of course we shouldn't be doing. They clarified that today. They basically suggested that there is evidence for mixing and matching vaccines, at least there is growing evidence on that front, and that people should adhere to their public health guidance, which we're doing in Canada. We certainly know that there's many countries around the world, Canada included, that are mixing and matching first and second doses of vaccine, and they're doing so safely.
Right, and we're hearing about booster shots, a third dose of the vaccine. What do we know about that for Canadians right now?
Yeah, we have to timestamp all of these conversations, but when we look at currently, right now, it does not appear that there's a need for a booster vaccine for the general population if you've completed your vaccine series. Now, that might not be true later on. We have to be aware that there may be a need later on down the line, but we don't need one now for the current COVID-19 that's circulating, including the Delta variant. There may be a smaller segment of the population who are immunocompromised who might need a booster vaccine, but certainly for everybody, that's not necessary at this moment in time.
Dr. Bogosh, thank you.
My pleasure.
Application in medicines. The infection is usually expressed with fever, fatigue, dry cough, breathing difficulties, sometimes a sore throat or increased nasal mucus, which we call rhinorrhea. Generally, they are mild manifestations and appear gradually. Some don't develop any symptoms, and 80% recover without treatment. In 81%, the disease is mild. In 14%, severe. In between 4 and 6 of cases, it leads to a critical state. We know that those who are most likely to suffer from the disease in its most serious form are the elderly, and those who already had heart disease, lung disease, diabetes, hypertension, or were immunosuppressed. Pros and cons. Pros: adaptability. We as physicians have known the world that we are malleable and adaptable. I am proud to see that we have stepped out of our comfort zones to manage ventilators, volunteers in emergency departments, and ICUs. We also adapt quickly to flu police and schedules as they evolve. Interface. Never in medicine have we seen such an extensive exchange of scientific dialogue across fields. Everyone joins hands with one goal: to alleviate suffering by empowering each other intellectually while fulfilling our duties with empathy. Telemedicine. 19 gave us no choice but to enforce social distancing. This opened new avenues for us to continue to provide care for our patients through virtual medicine, increase efficiency, convenience, and minimizing exposure to COVID-19 have been the highlights of telemedicine. Cons: uncertainty. Physicians around the world turn to each other on how to best manage a novel virus. What is the clinical course? Spread most vulnerable population. Normally, questions like these were answered by random clinical trials or meta-analysis. But in the brink of a pandemic, we now have a disease with no known treatment. All treatments are trial and error. CDC changes recommendation almost every other day. For most physicians carrying this challenge, are we trained enough to function in uncertainty? Physicians were learning as they go, and not being able to offer definitive plans for patients is extremely distressing. Shortage. The media The media has used word metaphors to portray the medical community's pandemic fight. In the light of PPE shortage, we were soldiers going to war on air. As we reuse our masks and have inadequate PPE, there were shortages of COVID-19 testing kits, and even healthcare workers who were exposed couldn't get tests. Hospitals eventually realized how ill-prepared they were with shortages of ventilators, beds, and personnel. Recommendations applied in Ecuador. Wash your hands frequently. Use soap and water or an alcohol-based hand sanitizer. Keep a safe distance from people who cough or sneeze. Use a mask when it is not possible to maintain physical distance. Don't touch your eyes, nose, or mouth. When you cough or sneeze, cover your nose and mouth with a bent elbow or a tissue. If you are not feeling well, stay home. In case you have a fever, cough, or shortness of breath, seek medical attention.
So we do know quite a bit about the risks of COVID. As I said, 80% never become symptomatic. 20% do become symptomatic, and of those 20% who are symptomatic, many of them are hospitalized, and about of those hospitalized, 15 to 20% end up being seriously ill. The ones who are
then of becoming seriously ill or dying are those who are older, meaning over 60, and the older you are, the higher the risk. And those individuals who have underlying diseases, diabetes, severe lung disease, heart disease, kidney disease, those people are at higher risk of having serious consequences of COVID. We've seen very few cases in children. They appear in general to have mild disease. So the answer is older individuals are at higher risk of many respiratory infections, including influenza and other respiratory illnesses. So certainly if you have a parent, grandparent, great-grandparent, and you are ill, meaning with respiratory symptoms, fever, shortness of breath, cough, then you should not visit older people, particularly if they're frail enough to be in a nursing home. You should wait till your disease has resolved before you visit them. Turning it around, what can the older persons do themselves? Again, particularly those that are frail with multiple other underlying medical problems, should obviously screen people before they come visit, certainly asking your children, your friends, please don't visit if you're ill. And second of all, particularly if we start seeing community acquisition, meaning cases in the community that are acquired and we don't know about, then to the extent possible, they should try and avoid situations where they're sitting for long periods of time with many people around them. Things like movie houses would be an example. And they should obviously try and see smaller groups of people and not into large groups of individuals. Obviously, if they see someone near them who's coughing, sneezing, and particularly not using a tissue while they're shopping, they should move more than 6 feet away. It is true for droplet spread diseases, you know, the official guidance is 3 to 6 feet. I'm being conservative, stay 6 feet apart, but that's about as far as the droplets go. Now we have some true airborne diseases, which COVID is not an airborne disease, but they would include things like chickenpox, tuberculosis, for instance, measles. All of those can be transmitted over many different feet. But COVID is not like that. COVID is only transmitted by a maximum of 6 feet as far as we know. It's a respiratory disease. These tend to peak in anywhere from early mid-fall to early spring. So as we go into spring and then into summer, I think that the number of respiratory infections from COVID as well as from other respiratory viruses like influenza will go down quite a bit. Although I can't guarantee that for COVID because most of us are susceptible. And I do expect, again, just my personal opinion, that next year when we have our respiratory season in the winter, we will see COVID peak again. And then after that, it'll just become a circulating, less common than flu, but circulating respiratory infectious disease. We need to save the masks for the people most at risk. There are certainly some groups of patients that should be wearing a mask, particularly when they're in social gatherings. Certainly a cystic fibrosis patient, if they might be near other cystic fibrosis patients, should be wearing a mask because they can transmit pathogens. Our highly immunocompromised patients who have undergone a bone marrow or a recent organ transplant, heart or lung, certainly based on their physician's advice, if they're in groups, a mask is very reasonable. So there are certain groups of patients who should be wearing a mask. Should everybody else be wearing a mask while they're walking around the street, going to the supermarket? The answer is no, because we do need to save the masks for our patients and other friends who need it for more serious medical problems, and for our healthcare providers when they're in close proximity to a potentially infectious patient.
Conclusion. So far, the National Institute for Public Health Research has taken 1,579,458 samples for COVID-19 RT-PCR, of which 467,073 are confirmed case with PCR test.